to sound. Make sure everyone can hear us. And we will begin.
Jerry's here.
Hey, Jerry, can you hear us?
What's my girl? I got a 30-second delay.
Yeah.
You kept them pictures at the bottom. Jerry hears us.
Mm-hmm.
So funny, these pictures. I come on here trying to be a professional about things.
You got a lab coat for Dr. Mike?
We gave him a lab coat too. We gave him a little lab coat for the doc too.
Hook him up. Alrighty. We are heard. Team Victory in the house. Team North in the house. I don't remember nobody else's team.
Boom. Updated doc.
Got their Facebook sound up.
Not me. I'm gonna blame Brett.
Definitely Brett.
Definitely Brett.
Alrighty, so I think that we are good to begin to roll.
Victory in the house. Team North in the house. Oh no, it was me.
Oh.
I thought it was Brett.
Man, I got here half an hour early. I did everything right
Hey,
tonight.
man, I said it was me.
Screen up. I'm on my best behavior.
I accepted
on mute.
responsibility.
It's early. It's early.
Hey, I just knew that was Brett. I didn't even look at my phone. I just knew it was.
You're welcome for my service.
Oh, there's Jeff.
No, my volume on my phone's turned down. I got the show streaming, but my volume's turned down.
We got real questions already.
Yeah, okay. That's for you,
Hello,
Doctor.
everybody.
Can we do the introduction?
Yeah, before we kick off.
They get straight to the
Yeah,
business,
let's
right?
get right to
I got
it.
a
It says a time limit.
Jesus. Oh, man.
40 viewers.
Yeah.
Where are y'all watching on the Mastermind?
Everywhere.
Yeah.
People on Mastermind, people on my page, some people on,
We live,
on
baby.
Terrell's page. We couldn't get Brian's in there, so that's fine, though. But we are here in full effect. They can hear us. We are rolling, so we appreciate
effects.
everyone being here. So let us run around and DP here. I'll let the rest of the gentlemen introduce themselves, and I'll let Terrell go last and introduce our special guest.
Welcome to the show.
All right, I'm down. Ron is here. VACI North in the house. How's everybody doing tonight? That's all I got. Brett, you're next chronologically.
Oh, what happened to the show on my screen?
What?
Do your intro,
looking
Brett.
at a black Skype screen.
Hey, don't worry about all that.
Yeah, we can
Go
see
with
you.
it.
That is your internet.
Camera
Yeah,
one,
so-
camera two,
The camera's off.
camera
Just
one,
go.
camera two.
I'm not introducing myself again.
I'm gonna just put an emoji over Brad and call it a day.
Yeah, there
What?
it is.
I was 30 minutes early. I was here tonight.
Yeah, 30 minutes to be
Intro,
17 minutes
Brett,
late.
so we can move on.
Do your intro. Say who you are for the people.
Hello. I'm Brett.
Alrighty, next.
Hey, Leader Team Victory, live from Orlando, Florida. It's your boy, Captain of the Power Hour, Captain of the Fist Bump Nation, bringing it to you live, raw, uncut. I can't see the screen. I'm just talking. Am I
That is
on?
literally you. Can you see things?
Yeah, it happened to me on Thursday too. You gotta not close it, but like close it. Like take off Skype.
Oh, I
and
see I'm on my
contact.
phone.
Yeah, that's fine. Yeah, it did to me too.
Hello.
Did you say Fist Bump Nation?
Yes, you did.
Fist Bump Nation, man. I that was back in December of the Power. I was like, why can't we start fist bumping? I'm tired of shaking people's hands because I got sick again.
So
Fist
fist
bump
bump
nation,
nation
man.
didn't work. You still sick now.
I'm
That
still.
means it
I
doesn't
got
work.
2 4-year-old kids getting me sick, man.
Air wave nation. Air high five. Don't touch nobody, man.
Can I
Fist
do my
bump
intro
nation.
now? Y'all good? You good? Fist bump
Yes,
nation?
fine, fine.
Awesome. Good evening, everybody. Terrell Morrell, veteran master coach out of the great state of Maryland, representing Team VA Avengers, and we have a special guest in the building this evening. Somebody I hold in high regard. Literally have known him my entire life. My mentor, my brother, one of my closest friends on this planet, and also a member of Team VA Avengers, Dr. Michael Smith Jr.
Thank you. And I appreciate it. Good evening, everybody. Like Terrell said, my name is Dr. Michael Smith, veteran coach, but I'm actually a podiatric surgeon. I did see a question up there earlier. I'm a podiatrist by trade. And what a podiatrist is a, in the state of Maryland, I've been practicing actively for the past 15, 16 years, but it's a doctor that's specific to all soft tissue and bone structures of the ankle and below. So that's in most states. There are certain states where that extends into below the knee or the lower leg and things of that nature. But it's state specific. So not every podiatrist necessarily performs surgery, but I actually did a surgical residency where I do procedures, things from broken bones, heel spurs resections, Achilles tendon resection and repairs, hammer toes, bunions, fractures, ulcers, wounds, amputations. Okay, and many of those things, and so. Board certification, you have to have so many cases. You have to sit before a board. You have to take tests and things of that nature. I always say I have this that I start with, that my introduction to the team started when I was about 3 years old, because that's when I had a little cousin born named Terrell Morrell. So I had known him all his life, like he mentioned, and our paths diverged maybe about when he went to the Navy about 17 years old, and I was in college. And then, reconvene more recently. So, in general, should I go ahead and just share a story or two or anything like that?
All of them,
Yeah.
especially the embarrassing ones.
Yeah. How you look? How Terrell look 10 years older than you?
So just
get started.
Before we get them going. So again, today, before we keep going down, we appreciate everyone who's here with us. We are talking about lower extremities, limbs, feet, anything that has to do with that when it comes to service members. Obviously, that's one of the biggest things, right? Everyone got bad feet. You've been humping. You've been doing stuff. All the issues we talk about, it's a common thing. So we are live in the Facebook group. We are live on Terrell's page. We are live on my page, and we are also now live on Brian's page. So we're going to be here until 10, and then we will swap and go into the mastermind. So we're sharing some information with everyone, but then we'll go back to our closed community for the members that we have after 10 and continue Q&As and things like that to kind of frame set what we're doing. So key points here, breaking news, you see it scrolling. Definitely make a point to reach out to your VC. There are some good changes and things happening. You definitely want to go ahead and ask your coach about some of the stuff that's happening right now to get you going. So back to the doc. Tell us that story you were about to say.
So no, in general terms, I mean, from before, I had a veteran. I remember, and I usually share this, and I'll share this with clients as well. But many years ago, there was a veteran that was injured in active duty, had a crush injury to his lower leg, and it affected his ankle. There was some, if folks are familiar with neuropathy pain, shooting pain, sometimes pins and needles, burning, numbness, tingling, funny feeling, fire. A lot of different sensations, and it's kind of either or and for each individual. But his was so bad, it developed a chronic pain syndrome, complex regional pain syndrome, RSD. It's a lot of different names that you hear. that then developed an opioid addiction that ended in him losing his life as he knew it, his wife, his kids, and job and career. And he was basically coming to me as a podiatrist, and I was working for a company at the time, but as a podiatrist to sign off on and make sure that there wasn't anything that I could offer him professionally to help him, because he wanted to get his leg cut off. And he had dealt with the fact and was going to live with the fact that it would have been easier for him to get a below knee amputation and live with a prosthesis than it would to be on the chronic opioids and things of that nature. And granted, this is probably a decade ago, even before the opioid crisis, and it became as big a thing more recently. And then there's another story that I often share. There was a veteran injured jumping out of a aircraft, broken hip, developed a surgery, and this is pre-VACI for me. Surgery, came into the office with an Achilles tendonitis that kept coming on and off, maybe quarterly it would affect him. Long story short, I diagnosed this veteran with a limb length discrepancy. One leg was longer than the other. I probed a little bit more. Turns out that was the story behind it. And I even remember the rating. He was 30% rated, but I didn't understand and know things at that time. It didn't really mean much to me. But in the end, I reflect on those stories, especially professionally, because there wasn't a needle, there wasn't a surgery that I was trained for, there wasn't a medicine, a brace, a shoe, an insert, nothing that I could use to help that crush injury to that guy's leg. Yes, I can help the Achilles tendonitis, but they'll be back. They'll never have a leg that's equal to the other one based on those mechanical issues. And so for me, when you put those things together and you understand some of the work that the company does with regards to how those things impacted somebody's lifestyle, for example, right? How those things, what the chronicity or the pain associated, what things couldn't they do as a result of some of these issues? And so you spin that forward, right? We have certain situations in the profession. I developed 2 years ago what we as professionals deem to be a march or military fracture, a stress fracture of one of the long bones in the foot, derived specifically, from things that pretty much every veteran that understands my voice probably has dealt with, if not ignored or taken Motrin for or whatever the case may be. These things, it's the situation where you can never put the toothpaste back in the tube, because things tend to always get worse, or you have to modify your activity till this day, or you have to wear shoes and just be mindful and things of that nature.
Well, I got to jump in there real quick. What did you say about the toothpaste? Because I know I've heard Terrell say that once or twice about the toothpaste back in the tube. That is not a first-time statement. I've heard that.
That's right. That's right.
I'm not just gonna let you slide with that.
That's
one.
Exactly right.
So
you squeeze the toothpaste, you can't put it back.
Everybody that is on right now, you see the question. This is we started doing this the other day. This is our roll call right here. Let us know, what branch of services you serve. What years were you in? Because at the end of the day, yes, we're here working with veterans. We're going to answer some questions. We're going to try to give some information and go from there. But we definitely want to ask those questions. So I see some comments coming in. So as we talk, you'll start seeing me pop some of those up. So we appreciate everybody right now. A lot of folks, a lot of questions. So one of the things I guess I'll start with asking is, and you might have kind of glossed over it. So if you had to tell someone who were to say, hey, doc, in the military, we all got foot issues. I can still walk, right? Because sometimes, you serve for a few years. You think that, things will kind of go away, right? So can you speak to what happens with the chronicity, the compact, when things begin to compact and kind of over time become more chronic? Because you know how it is, right? It's one of those things where it's like, that's a thing, right? So if you can address that. And then the other part is, for a lot of veterans that don't have records, we always try to give advice and say, when you go to a doctor, they can tell the chronicity of the situation you have. When a doctor looks at you and says, "Hey, Brett, you either play football, jumped out of an aircraft, or something," because the
Right.
way you jacked up, that's not normal wear and
Right.
tear. And when you tell a veteran that, they don't understand because the doctor might not be able to attribute where it's coming from, but at the minimum, they're able to see the chronicity and say, "Hey, DP, this didn't happen last year. You've had this for about a good 10, 20 years." So the first part of
Right.
how things evolve over time, and then being able to now look at that and see a doctor. So basically both points, right? How the doctors can, look at the chronicity part there as well.
That's a very good, kind of point, question, and segue, because it actually was coupled with the "you can't squeeze the toothpaste back in the tube" analogy. What I meant by that, or what I was referencing, was the Achilles tendonitis example that I use will never not be an Achilles tendonitis issue, because that gentleman always will have a leg longer than the other, probably about an inch. So they'll always need a lift in the opposite end.
Mm.
And these things always just get worse. They never get better. I'm not saying they'll be debilitated necessarily, but as we mature, as we age, we might gain weight, right? We lose muscle tone, we lose bone quality and overall strength. Normally, right? We can live healthy, active lifestyle, but
But doc, but
imagine,
doc, but doc, I'm
yeah,
getting old. I'm old.
yeah,
I'm getting,
yeah,
weight. It's not the military. That's just me, right? That's just the my
yeah.
my disabilities have no effect on my weight gain. That's just me
That's
being lazy,
aging.
right?
That's absolutely not the case.
Okay,
as,
okay.
as,
Because that's what they told me when
and
I got
as a
denied.
as a matter of fact, to the other part of your point, the way that I would suggest that veterans help paint this narrative, so to speak, is by sharing the narrative. It's been far too often that I've been on the clinical side and I had no idea this person was ever in the military, ever, right?
Mm.
For foot issues. And so if I poke and prod, which I usually do in my detailed history and physical, but some people are not as forthcoming, about the connection here. They might just say, "How long you had this heel pain," right? And they'll say 6 months, but you failed to mention that you were active duty for X amount of years, and these how things go. So if you at least introduce that, first of all, you have to have a decent rapport with the doctor that you're with, if you can. Sometimes you get selected or given a specialist. All depends if you're going private or VA or whatever the system is. But you want to try to develop a rapport with the doctor if you can. I know it's not easy, but sometimes it should be. As a matter of fact, if you don't like a food that a restaurant is cooking, you go to a restaurant usually. So you usually want to do your health care the same way. Choose somebody who's going to listen to you, or at least you feel that gives you appropriate time. So that's a big part. The second part is tell your story. Create a narrative. Even if you got to jot down information, written information beforehand, you fill out paperwork, intake forms all the time for any doctor that you go to, especially when it's new. Create, tell that part. You remember when your feet hurt. You remember when it was wet in your boots and you still got those nail changes and the skin changes, and all of those things, right? All of our feet change with time, but not everybody spent miles with 50 pounds or however many pounds extra on their back doing these things. So there absolutely is a ongoing chronicity to these things, and is accelerated in professions like being in the military.
Mm. Now, and I'm gonna pass it off to the fellows here in a second. So, can you give me your opinion? Take off the VC hat. Take off all that stuff. When I tell a veteran, when we talk to them at times, and they're like, "Hey, you know what, Brett? I'm gonna go to the doctor. I'm gonna go ahead and try to get them to do something for me." At times, I don't think that people understand that when it comes to disability from the VA side of the house, it is a very different conversation to disability in the real world. Arguably, we've said, right, 1 to 2% of the population is ever served, right? Take from that another fraction and say who's actually had a disability. So at the end of the day, when you say disability, it means one thing in the real world. In the VA, it's a different story. So, as a medical provider, when you hear the word disability, what are the things that are happening with your license, with legal malpractice, all of that happens? Can you talk about that? Because I don't think at times we understand that what we're doing is actually hurting ourselves, right? I'm going to see the doctor. I need a statement of facts. What do I have in chronicity? I don't need your opinion. Now, great, like you mentioned, if you have that rapport, gravy. But if you can't get that, at least get a statement of facts so that then a med team or another provider can start to piece things together. Because I don't think we recognize that there is a difference between that. So can you give a little bit of like if you? Cause I would make the example being non-medical, saying if I had a hundred patients, right? Out of that, 50 are trying to file a disability. 2 are veterans. Guess what? 48 people trying to do a thing that I don't want to get involved in. So the 2 that just need me to give an opinion, I'm like, whatever. You're trying to do what the other guys are doing. What is the thought process when you hear disability from the civilian side?
That's another good question. There are whole practices, no matter the specialty, and you could tailor your practice in general to what you want. So there's whole practices, for example, that might take cash patients only for whatever they do, right? Some people don't take insurances. Some people take limited things. Some people don't do any disability stuff at all, right? And I've actually always been closer to that kind of practice or involved in that kind of practice. The first time I heard DBQ, even though practicing 15 years, was here, right? So if somebody came and told me or asked me to write a nexus statement out of those 100 patients, I'm not really going to know what they're talking about. You can have your medical records, Miss Johnson, or, whatever. We can print a copy for you, and maybe we won't charge you this time, but I don't, So that can be closer to the it can literally be, maybe you can have a whole professional, never mind the verbiage and the specificities of how it goes, right? Never mind that before we get to that. But you can have a whole professional practicing for however long, not necessarily understand the specifics, that are needed from the side that we're referencing. So private world or kind of just, it's hit or miss. Maybe somebody might be willing to write a Lexus statement. You'd probably be closer to somebody and you can explain that to them a little bit. Or if there's some kind of example or whatever the case may be that you could offer them, that's the only way that I would even see it. I almost think you got to go. I think that's why it's so good. You almost got to go into it assuming they don't know or can't do it the way you do.
So what is the fear, or what's causing that hesitation for those that don't understand? Because rightfully so, the veterans are having a conversation, and we're gonna get agitated. Hey, doc, you don't understand. What I need is this. But again, I'm one of 2 people asking this question. What are the other 50 people potentially doing, and what infractions does it have on you, your practice, and your license as a whole? Because we have to understand how we're asking what we're asking and why we meet the resistance that we meet.
Yeah. Okay. So again. So all right. So let's take my practice, and we accept insurance, right? So you going in, just try to be as transparent as possible. There's certain, say, levels of service that I might bill, right? And let's just make it real easy. 1, 2, 3, 4, right? 4 levels, okay? Mostly on and let's do it with time to be broad. So say 10 minutes and below is a level 2, 15 minutes is a level 3, 25 or more minutes is a level 4 and beyond, just broad instances, right? That is, in general terms, you're supposed to try to build in a records review, a face-to-face encounter, any diagnostic stuff, and then your notation, right? In private world, you then have to submit all of that, make sure it lines up, bill with codes. We've seen these diagnosis codes on the forms. Bill with codes, submit it, and send, and hopefully you get paid in 30, 45, or 60 days, okay? That's a rough thing of how it goes. Part of the issue is that if I have 10, 2 heel pains, right, and I got to inject them, boom, boom, and then I got orthotics for this guy, I got an ingrown nail, so I got to numb him up and go back, and I got to bill and code all of these things to get paid for these procedures and services. There is no code for paperwork. So you would have to bill around or charge a fee around filling out paperwork that still requires a records review, all these things, and maybe a face-to-face thing. So if I had a vet, I filled out some paperwork the other day for a veteran, but they came in with the paperwork. She was ready. It made sense. And in the moment, I was able to stop and fill out the paperwork for her, but it took me 7 minutes, let's say, beyond. Doesn't seem like an eternity. But if your grandmother waiting and like 2 other people was waiting in the waiting room, I can't stop in my day to fill out that paperwork. Now, I filled out the paperwork that just basically said that she was coming to a civilian doctor, and that was becoming part of her records because they was kind of giving her the runaround about foot pain, and she was in tears in the office. This was like 2 weeks ago. She was in tears in the office. So there's no code for paperwork. I billed a new patient consultation for her, and I billed her x-rays. That's normal, and I was able to fit in that time 7 minutes of paperwork. But if I got some paperwork and you want me to generate letters and you want me to, well, doc, that's not right. I don't get paid to kind of handle those things. So I think that's some of the resistance, unless you got it set up or network, hint, right, where you understand how they roll. Again, you hit or miss. You dialing out a yellow pages, and how old is that to try to find somebody really knows that process thoroughly enough?
Interesting. I'm gonna let Ronis jump in or Terrell run in because I have a whole bunch of questions.
I know. I see, man. I see. You was asking all the good questions. I guess I'll give something simpler. I guess plantar fasciitis seems to be a big thing. I suffer from it pretty badly. I wear the boots every night, both feet. Every morning is terrible. You know what I mean? I got the custom inserts, but it took a lot to get that. People don't, and again, it would seem that a podiatrist would understand, like you said, but it's like, man, nah, this hurts, man, and nothing's working. And they like, all right, and it's like you have to go through those steps, like go to Walmart and buy this cheap insert. Like, all right, that did nothing. All right, let's try this one then. Like, no, okay, then it was the mold. And then it was, all right, man, wear this thing at night. And then it was like, all right, that didn't really help until literally I got these big moon boots, man, that I kind of have to wear overnight. But I guess a lot of people, and again, I don't know percentages of podiatrists or people that suffer from plantar fasciitis, but it seems to be a large percentage of service members. So I guess could you kind of explain what it is and I don't know if what the difference between that and pes planus is too, because with the CFR they get grouped together. Yeah. So I'll go over that, and that's good. Pes planus and plantar fasciitis are 2 different things clinically, and I'll explain the difference just in general. All right, so underneath the foot at the heel, right, and I'm going to use my hand as the example. The heel, and you understand the ball of the foot, right? There's a ligament. In ligaments, we talk about ligament connecting bone to bone. So the heel and then the ball of the foot. A ligament is called the plantar fascia. All right. So when you hear the suffix itis, it talks about swelling or inflammation. Plantar fasciitis. That's where you hear arthritis, swelling or inflammation of the joint, right? Tendonitis, swelling or inflammation of the tendon. Plantar fasciitis, swelling or inflammation of the plantar fascia. More often than not, that usually occurs at the insertion or the origin of the plantar fascia at its heel point. So sometimes that's right underneath, sometimes that's on the side, right? Sometimes that's on the opposite side, but it comes from, every step that you take. Okay, I call it the penguin shuffle. You're getting out of bed in the morning, you gotta hold on, and walk to the bathroom. That can hurt those few steps. So why does it come on? Usually I'll say foot type, the type of ground you walk on, the type of shoes you wear, weight changes, weight gain specifically, changes in activity level, right? So this is, you can instantly, with those characteristics, understand why military veterans are a target for this. So are police officers, so are food service workers, any big box stores, Home Depot, Lowe's, Walmart. Hard, unforgiving surfaces for hours on end. You guys add into terrain issues and uneven surfaces. You guys add into shitty boots. I don't know if they bad or not, but not good supportive situations, right? Add into friction and all of these things. And so
you can get a chronicity, an ongoing event where the fascia gets relaxed or tightened, kind of at rest or at night. And when you go to stand on it, it's pulling, and it's the pull and the insertion, inflammation around that area that really is agitating the nerve in that area. So it'll feel like maybe hot poker or some other kind of pain, especially as it ticks up. I want to connect. There's sometimes some other things that go on, some tight hamstrings, tight Achilles tendon. That's why you got to wear the night splints to try to stretch that out and kind of keep it as stretched as possible, right?
Calf strain too, right, Doc? Calf strain too, right?
That's exactly right. That's exactly right. The plantar fascia is in large part responsible for arch height, right? So as you stand, as you walk, as you march and do those things, it's getting stretched and strained.
No arch here. It is completely flat. I have none.
Absolutely. If it's under supported, it will become inflamed and irritated. And this is where you have the issue. We often kind of, again, gain weight and all of that. So you got to support the arch as one main tenet to treatment. Also, getting rid of the inflammation. So whether that's by mouth, medicine, rub on, or injectable, people know cortisone. Sometimes it's surgery, but it's one of the main arch supports. And as we mature, as we again gain weight a lot of times in maturity, or don't have foot structure to begin with, birthright with no arches, little no arches, 2.5 times your body weight with every normal step. So imagine that pounding on your feet, especially, then you're only accumulating more of those steps as you mature. We're living longer, healthier, more active lives in general. So people tend to have a lot of foot problems. And I like to say, if we all live some level of active lifestyle, we all have some kind of itis or arthritis or fasciitis or something thereabouts. So that's a pretty broad overview. Just to touch on pes planus. Pes planus specifically speaks to the flattening, like you said, of the arch. So you can have, in theory, not more than theory, you can have flat feet, have decent support, understand how to support them, and not have pain, right? Not have the inflammation associated with the plantar fascia. But usually pes planus also incorporates some other muscles and bone structures as well, and definitely need some support. I can't say that I find it surprising that they couple those things together, because there's some other things that, medically they couple together that doesn't quite make sense, but it might just make it easier for them that way.
Yeah, and as we know, we do that. They do that with a couple other things too, hiatal hernias and GERD and so on. So, yeah, thank you. Definitely appreciate that.
No problem.
Come on, Brett, use that soulful voice and ask some questions. Or not. Or not.
What is going on?
We can hear you, Brett.
Now. Can you hear us?
Well, he figures that out.
All right. So
So one of the things I'll say then is I think it's helpful to have this conversation because, again, when it comes to any service member, lower body, the strain, you sign up, you go to service, you're made to do things that maybe you never did, right? There are those people who, ran track, did things, and there's those people who've never done anything, and immediately you're going to do 2 miles, you're going to ruck, you're going to do all these things that your body's not used to. Can you speak to the complexity of the lower body, right? If someone doesn't work out or doesn't take, do certain things, right? You're gonna get sore. You might, pull a muscle, might hurt your back, and people neglect at times because you're always on your feet, right? Because you're always using them. You don't think of the sensitivities that are in those muscles and those ligaments because of the fact that you're always on it, right? So if we all decide to do this crazy CrossFit thing and pull a muscle, it's like, okay, this is horrible, whatever. That'd be a different story. But when it comes to this here now, looking at the feet, right, for many service members, depending on what they did, they pushed themselves to a point where it created things where you might ignore it or whatnot. So can you talk about the wear and tear that's natural compared to what you've seen with either athletes, right, or service members?
Right. Listen, I couple
service members with athletes. Somebody mentioned earlier about a chronic looking foot, and you'd be like, Doc, this didn't, start yesterday. I try to make it my point to point those things out. Sometimes you just see something incidentally that doesn't hurt them. You'd be like, yeah, you used to be a ball player, or were you in this, or did you dance, or did you? And they'll say, yeah, how'd you know? I say, because these are the changes that you see. So it definitely is accelerated more than your average individual. You might start to see a lot of chronic things in many patients that might be 60s, right? Not like, and what I mean by chronic things, you might start to feel the stiffness. I didn't do anything. It starts to maybe limit you, and not limiting like somebody 60 can't run a marathon, but limiting where you might have to modify activity if you were a baller or a veteran. Okay, and so I give a specific example. I had a lady, and she's in her 50s at this point. I think she's Air Force veteran, and she had an arthritic big toe, and that comes from these PT tests. You got to bend and do certain things and move certain ways, and that bone on bone situation that can happen. And if you under support the feet or fail to understand some of these things, it can accelerate it. So I'm not saying that she had the same toe as a linebacker in the NFL or anything, but it definitely was the same surgery as a linebacker in the NFL.
Come on, Doc. You went to boot camp. They went ahead and said, look, pick a size 8.5. You're good to go. There's no real benefit in buying these sneakers. What's a foot type? You wear a sneaker, you run, and if it hurts, it's just because you're weak sauce. You know what I mean? Let's stop. What are we talking about here?
Yeah.
All sneakers are the same. Adidas, Nikes. What's the difference, right?
So you're right that's the common societal thread. Is probably a direct quote from the military. I told you another lady was in tears. There's a reality, right? If you have the option to go to a running specialty store somewhere near you all, wherever you are, right? I often tell people plan on spending a half an hour, 45 minutes. I don't even really care if you have pain right now. I say that to say, your feet, everybody's feet changes with time. People that have been active on multiple steps change a lot. They're wider. We don't have the same shoe size that we had when we joined up in they don't grow like with teenagers or anything, but we swell. It's a lot of different things that can happen. And so we have it backwards when we say, let me get these old ratty gym shoes that I had and let me go start to work out. You should be absolutely investing in some kind of workout shoe or something that supports you in the right way. And to really understand that, you probably got to go into one of these a running store somewhere where you know where your hot spots are or your pressure spots are, or
so
you know
not
the shoe
so
style.
not just trying to charge me $100 for some fancy crap that I could have got the Shacks at Walmart. Is what you're saying?
If you don't
say
understand,
the Shacks.
Yep. $29.99.
This how I break it down to people, right? You'll go into one of these fancier running places, and they'll have 3 rows of shoes. Broad brands we know: Brooks, Asics, New Balance, Adidas, Nike. Right. The first row is for a type of foot type called over supinators. The second row is for a foot type called over pronators. Third row is for neutral foot type straight lads. If you don't understand that with foot problems, you're already doing it wrong. Right? Because if you buy the same brands, but if you buy one that has your foot for foot types that lean this way, one is for a straighter foot type, and one is for an opposite foot type. And these things exist. These brands exist, these models exist, but there's room to be understood even as a baseline. That in and of itself is a narrative that can be created in a doctor's office. Hey, I got to buy a so-and-so and so-and-so shoe, doc, and it started when I, had it here. Shoes should be looked at as an investment. There are certain even stores that have a wear and return policy you might have to invest in. I like patients to experience what it's like to put their feet in shoes, and we don't sell shoes or anything, but put their feet in the shoes and say, oh, that feels good. Because there's likely a shoe style or stylings that can get you there, but you just got to go through that process.
Come on, man. You ain't trying to tell me they got the Cadillac of shoes out there and sneakers, man. Come on. It's like,
Bro.
I'm going to tell you.
Dad, shoot New Balance. I got to wear New Balances now, man. My feet.
Stride right.
So this is a
Stride
good
right.
point.
Those are kid shoes.
This is a good point to very quickly make a
Lost
quick
audio for a little
disclaimer
bit, so forgive me.
here and just point out that this video is for educational purposes. We are sharing information. This does not replace, obviously, medical advice or opinions. Please seek out that. We are veterans having a conversation with a doctor and asking the questions that regular people would ask if they had the ability to ask these questions at a coffee shop to be able to be informed and then go forward and make those decisions. So it's educational purposes. Definitely seek out medical and legal advice as you need it. Back to the Cadillacs.
Oh, okay.
Can I ask real quick? I had a client today ask about drop foot. Can you explain drop foot, Doc?
Yes. So drop foot, and that's a drop foot. There are a lot of different conditions, or many conditions, that might not start or start in the feet, or are specific to the foot, meaning the structure below the ankle, literally, right? 26 bones and multiple joints and ligaments. But drop foot is one of them. And basically what happens is it's a loss of motor, the ability to move kind of even just up and down, loss of motor for whatever reason, okay? And it often results in this kind of floppy foot that even has an audible slap to it, okay? And so you're talking about things from strokes that can cause it to back injuries. The arthritis in the back, low back, DJD, right? Sciatica issues could cause these things, drop foot long term. One might need to wear what's called the AFO, or ankle foot orthosis. It's a long brace that's customized for their lifetime that they got to wear inside of a shoe to bring the foot up so that their foot can clear the ground and not drop, drag, trip them, and make them fall.
Okay. So we have a few. So we're gonna start shifting a little bit here. And again, these, for those that have never seen these episodes, what we try to do is really bring someone in and bring some real knowledge to the conversation. Right? We're experienced talking to veterans. We have a background. We've seen things. But when it's all said and done, right? If you want to talk to about something, pull the specialist and have a conversation. So we appreciate you, hanging out with us this evening. Those that may have seen, we're going to post it next week. We're bringing an internist and rheumatologist talking chronic fatigue syndrome, fibromyalgia, and things like that. But in this case, I think this was a great way to start this conversation, because there is a lot of ignorance and a lot of individuals that have just been dealing with these things and just don't know what to say. So if you have some questions, please start posting them. We're going to be able to pick them up from Terrell's page, from Brian's page, and my page. The mastermind will pull them after. So what we're going to do, we're going to segue back into the mastermind group, which is only for the members, and we'll continue the conversation there. But we wanted to kind of show some of the things that we do behind closed doors, because sometimes I don't think people get to see that, right? Like, what are you guys doing in your group? What happens if you join? Well, this is a typical Friday night that'll go on for a little bit, right? So this is what you would call a little taste sampling, if you will. But we have a few questions. We're not going to get too complex. Understand that some details, when you ask them, right, it might not completely address what you're asking, but we're going to need more details, and we're not going to put people's business out there. So I'll start scrolling to some things here. A few questions that came up, Ronis did ask them, the common ones with strop leg, plantar fasciitis, and things of that such.
I have another question.
Yeah,
it's not going to be helpful to anyone but me.
You are a selfish man.
Yeah, well, so back when I was being a terrible soldier, I had very smart people in my life that I tried to be smarter than. So one of the things that came up is that PT, one day I had wore ankle socks instead of like the calf socks or whatever. And it was like, yo, it has to be over your ankle and whatever. And I was like, well, the ankle has 3 parts to it, and it was over the bottom part. Is that true? Or is that something I just made up on the spot?
I love it. Look at face.
Don't give me no face, man.
Patty.
That's why I said it's not going to be helpful to anyone but me. I need to know if I need to go apologize or if I was right.
Keep that Michael Jordan crying meme over Ron's face right now.
I've never gotten that question. That's a stumper, and the answer is like it's kind of not wrong.
Boom.
Get out of here.
That's it. No, because they said like the bone that you think of is the ankle, but
Right.
like the heel is part of like the ankle too. And my ankle socks covered that.
So not so much the heel
Give
bone,
it to
but
him.
the two bones on the side that people look at as the ankle is not truly the ankle bone. Those are actually leg bones, right? The tibia and the fibula, right? So when people say high ankle sprains, those are actually a diastasis or separation between the leg bones. That's why it takes longer than to roll your ankle, ankle sprain when people talk about it. And sometimes high ankles even need surgery to fuse those two bones. So that the true ankle bone is called the talus. It sits right below those two bones on the side of the ankle, and it helps swivel in that kind of 360 motion.
Yeah.
So I never heard that question.
Sounds a lot like Ronis is right.
Yeah. I mean,
no apologies. No apologizing.
Doc, when T said he was bringing a doctor, I'm like, okay, T, but you are a doctor, man.
Sergeant Slaughter, if you
ever... Whenever you know me to lie.
You know your stuff.
I want my Sergeant Slavic, if you're ever watching this at any point in life, just know that I was correct and I could wear those socks. Thank you.
There you go.
There you go.
You get that. You got the chip right there.
There you go. There's your little look. There's your little chip. Look up. Look up. Look up. Now go ahead.
I see it. I celebrate it. I try to
put it in your hands. Pick it up with your hands.
Oh, wrong side.
Little hands.
Here's a softball one, obviously, and again, not getting too granular and getting into strategy and things like that. I'll toss this one to anyone that might want to give a quick opinion on it. Obviously,
I think Dr. Mike can do it.
So the question is simply, can it be service connected? Because now we start to look at, obviously we're going to have missing piece. You have to look at everything. Time of in service, things you did, length of time out of service, that you have records in service showing a thing. We talked about the chronicity aspect of being able to show, is this something that just happened yesterday, or is it something that you can look and say, no, you've had this for a while, and then start to make the argument backwards to show you came into service, didn't have these issues, everything was well, you left at an exit physical, you may have complained, or afterward you complained because you didn't want to say it on record. Do you find in your time of practicing that patients at time will downplay symptoms to not truly deal with the issues they deal with? And I mentioned that because we had a CMP prep and we're talking about mental health. And sometimes there are veterans that will truly not speak of what they're dealing with, because if I really told you, psychologist so-and-so, let's say if you were, or the CMP examiner, my truth, I don't want to say a thing so you see me away. And mind you, I'll never see this person again, right? People literally have self-sabotage in a CMP exam, right? We're talking disabilities. And the inability to truly just, for a second, and you'll appreciate this. One example I've used a lot recently is when it comes to mental health, when it comes to disabilities, when it comes to these issues, a lot of times we've internalized it and made it part of our identity, right? And for many, they didn't even know it was not part of, it wasn't not of them, right? So for mental health especially, it's like, well, this is who I am. This is how I am. And then eventually you find out it might be PTSD or it might be other things. And then it starts to dawn like, wait a second, so Uncle Bob is just not the way he is. He actually has a condition that caused that. So for all that to say, for a lot of veterans, the example I've used recently a lot is that if you were hit by a vehicle and you had a limp, are you the limp or did the vehicle cause the limp? And when it comes to mental health, you forgo the vehicle and you walk around like I'm just a limping human being. And it's like, no, you have that. That's a part of you. But don't mistake that that is not your identity. There was a time when you didn't have a limp. There was a time when you moved and you danced and you ran. And today that's not the truth. And in mental health, for many, that's what comes down, right? Many Vietnam veterans, they are listening to this and may see this, will know that when it's all said and done, people know how you were before that time. And we have a lot of Vietnam veterans, but it's like, for a lot of you, your kids don't know that you were a dancer. Your kids don't know you are the life of the party. They know this grumpy person who doesn't talk about service, doesn't share because that's what you do, right? You just suck it up and drove on. And for 40 years, you've been sucking it up and driving on. And I implore anyone who is going to file anything, you have got to get into therapy, because the only thing worse than realizing that for 40 years you've been walking with a limp that never was really yours, that it came from service, is that reality. And that's going to hit you hard. And if you don't have the coping mechanisms in therapy to deal with that, the worst thing than knowing the truth is now knowing the truth, right? Because I didn't know why I did a thing. I didn't know why I drank. I didn't know why I did X, Y, Z. But now when you know, all that makes it worse, because you're not going to stop. You're still going to do those things, but now you know, like, man, I don't know I shouldn't be doing this, but here I am again.
Yeah.
And now that's going to take you down a spiral that if you don't have those things in there, right? So this disability conversation, it's about getting you the service connection to get the treatment and care you deserve to be able to work through those things. Many of you are going to, at best, baseline and at least hold where you're at, because many of you are spiraling, right? Maybe some will improve. But the fact is, some injuries, whether physical or mental, are just getting worse and worse, and you have to try to put a stop on it. So, so that's one of the parallels that I talk about when it comes to, you know, being able to identify with that. So when it comes to the physical side, it's the same thing applies for many individuals, where it's like, you know, you're 50 years old, you're older. The fact is, there's an 80-year-old guy right now riding a bicycle cross country, fit as ever. Age is not a thing here, because we always say, hey, Doc, it's the age, you know, come on now, I'm old.
Nope. Yep.
Your thoughts on that?
DPI was saying for that, I don't know if you guys ever heard this. It's like, once you squeeze the toothpaste out,
you know what?
You can't get it back in the tube. I don't know if y'all ever heard of that. I don't. I
couldn't hear it, but I hit him with the horn.
You can't get it back in. I made that up.
I said, say it again for the people in the back. You said when you squeeze the toothpaste out, you can't put it back in the tub.
Listen,
a rising tide rises all boats.
That's the one.
You heard it here first. Once you squeeze the toothpaste out of a tube, you can't put it back in.
Or you don't have the skill set to do that.
It's true. It's not
manual dexterity to do so. Steady hands.
So to close out this, the answer to this is yes, it can be service connected, but there's going to be certain things that have to be in place to argue this, right? Is it a primary? Is it a secondary? Do you have the key pieces there? And that's where you'd have to be able to make an argument. So realistically speaking, a lot of things can be argued, but you have to have the proof, because this is a conversation happening via documentation. Someone will not see you. There is documents going forward. So it's like, hey, Doc, I'm coming to you without documentation. You know, this is not treatment you're going for. You have to present the finalized product for them to work with you. And sadly for us veterans, and especially the older ones, you're coming from a disadvantage. Records were lost. Things were not digital. We get it. But yes, that's the short answer on that one. It can be.
Terry said their bread is, you've been real quiet tonight.
I'm so impressed. I'm just listening. I'm learning over here, guys. This is good stuff.
My bad,
Doc. Doc, do you
softness.
I always tell our clients, my coaches as well, do not forget to explain the quality of life issues to your doctor that you're having with your musculoskeletal issues. Don't just go in there and talk about you can't bend it or it hurts when you want to hear about that too, right?
Yes. Yes, absolutely. I think you get a chance, what brings you in and things of that nature. But like, yes, you would weave that into it. And you should, again, because that helps. We write as on the doctor side, we write a subjective component. So that's a narrative as part of your normal notation. And you got to help paint that. If you don't tell me it's a 7 out of 10 pain, I won't know it's a 7 out of 10 pain, right? If you don't tell me it was from this shoe or this time this happened, I won't know. If you won't tell me that you can't do the treadmill or you can't run the half marathon that you were used to,
right? And now, like you used to before this happened in the military, then I won't know to even put it in the notation. So yes, to your point, I would bring it up
Come on,
as
come,
you know, one of the first
Doc.
opening
I
lines.
gotta call a bluff, man. You coming at me with all this stuff, and none of that stuff means anything, man. Just because you can't run and you can't do all the stuff you love to do, that does not affect you psychologically. That stuff don't bother you. It's physical, man.
Well, let's talk about how it does. Chronic plantar fasciitis, right? You can't exercise the same. Sometimes it might take months to get by. What if you want to need surgery? Maybe you need steroid dose pack or steroid injections. Weight gainer, right? Your lack of reduced exercise can lead to increase in hypertension, increase in cholesterol, diabetes.
You talking secondaries now, doctor?
And depression.
Depression.
Sleeping with
No,
those things.
there's no depression in this. Come on.
Wow.
Sleeping with those boots is depressing.
All a cycle. All a cycle that's related. And the depression and anxiety raises your sugar levels, your cortisol levels, and causes the same issue. Mood is affected, sleep is affected, pain is increased, and your body is not allowed to heal the inflammation that's the problem to begin with. It's absolutely a chronic pain, a lifestyle impact issue more than it's just inflammation in your heel ligament.
So you're saying the song we sang when we were small is true? That one thing's connected to the next thing and it affects the other thing?
To the hip bone, right.
Come on, baby.
I've seen a tight hamstring lead to fasciitis, absolutely.
When the toothpaste gets out of the tube.
Name 3 of the bones in that song.
Doc, we got a question here for you. Tingling across the top of both feet, is that from back or something when you start to have those tingling sensations, numbness, and whatnot?
So it could be either it's specific to the foot or it manifests in the feet. So if you have a back condition, and really I don't say no matter what, but really no matter what, usually lower or lumbar back, motor vehicle accidents, DJDs, discs, or whatever, stenosis, whatever your diagnosis may have been, an injury, right? Then you can get what we call paresthesias, not normal feelings, numbness, tinglings, funny feelings in the feet because the L level, low back level, the end signals manifest at the tips of the toes. So yes, that could be back related, but it might not be alone back related. You could get isolated pinching in the bones in that area of the foot that might be related to your shoes or your activity level that could give you also some numbness across the top. So that's where that you got to get evaluated and maybe see somebody or go through it might matter.
So for those that are kind of catching the drift, and again, these are things that at times, we try to create the banter and we try to talk because it's, some of these subjects can be dry. This is, not one of the ones that is as, tough as others, but the rhetorical questions are the questions we hear all the time, right? And I think it's just good to be able to give the audience the ability to see those questions that they would have asked here. But this really begins to segue now into secondaries because what you're saying, Doc, here is that something can cause something else, right? So if I'm tracking with you, right, I got bad feet because I done hurt myself, but you're telling me that there is a possibility, granted there's life, there's not saying that this is the only thing causing it, but that this can make something worse, aggravate a situation like my knee, my gait, the way I walk, my back, all those things can be connected, arguably, if those pieces are there.
100% true, yes. The joke that we talk about the song, hip bone connected to the knee bone, is actually true. Hey-o. Your kinetic chain, right?
That was still
the way you walk, gait. These are terms, basically how you walk. You can get, if you carry too heavy of a computer bag, you can have foot issues as a result.
Wait a second,
people don't even understand.
You trying to tell me that a 98-pound, 4'11", she got on a tippy toe, female or male, because we got, you see both of them, who now got a ruck march with how much on their back? That might throw something off. Man, you talking that
100% yes.
You talking that crazy talk. You might as well be a chiropractor now.
The reason why we talk about night splints and needing to wear those night splints for fasciitis is because that is a mechanism that's stretching the calf muscle and Achilles muscle. Those muscle bellies start just below the knee. They already are part of the knee complex. If that's messed up, then we're talking about the knee. Rest in peace, Kobe Bean Bryant. Tore his Achilles tendon, came back seemingly prematurely, developed a stress fracture in the opposite leg tibia. That's not a coincidence. You see it all the time in professional sports, right? So it's no small leap. It's an easy little branch, limb to go out on to suggest that these things, once you get a joint or one joint lock, that big toe joint arthritis develops midfoot, ankle, knee. It goes right up. Midfoot, ankle, knee, back, shoulders.
Wow.
It's
So
exactly
here's the flag on that play. Question for you, that. So let's use an athlete, right? Because we talked about when you look at athletes and service members, it's pretty much the same. So will an athlete, professional, what have you, that has the ability to stop, find another endeavor, stop pushing past a certain point, versus a service member, right? Because when that athlete hurts themselves, they get sidelined. If they're on salary, they have the ability to do stuff. And guess what? Maybe you play for 7 years and you retire. You try to tell me that someone can be in service with a similar type of injury or aggravation, and the fact that this is all they got, they're going to shut up, not say a thing, and push through the pain, pop as many pills as they got to, because guess what? I need these benefits to take care of my kids. I got to do what I got to do, because if I'm not in the military, I don't have nothing right now. Is that a reality for some people?
As a matter of fact, man, people, yes, is the short answer. People are almost worse than athletes in that instance, because they're not going to pay you $20 million to rush back or do something or ignore it or whatever the case may be. And I don't say worse in a sense, because life is life, right? Things are really going on, and so it's almost like the mentality, you got to do what you got to do. Hey, you're a soldier anyway. You're better, so there's a toughness that whether you had it innately or had it developed, that you kind of motor through. But there's certain things that you should not just push through. If anything, you got to look at and try to peek around the corner and understand what's going on. That you don't want to be, 60 and can't play with your grandkids or whatever that may look like.
Look, man, he's 60. He's old. He's slow. That doesn't affect him, right? You just, come on now. That's
bones
nothing.
degenerate. They don't regenerate.
Right. I replaced a lady's joint. She was late 30s. Replaced her big toe joint because it was arthritic and beaten up. She was the Air Force lady. They don't care.
Because the point to that is that the one thing Ronis, would you concur? Brett, would you concur? Terrell, would you concur? Doc, would you concur? Is it's age, man. I'm old. It's aggravated. It's degenerated. Come on, man. I'm 50. I feel like 60. I'm 70. I feel like 80. Like it's just wear and tear, natural stuff. I don't have an argument to make.
No.
I tell you, man. I think you're a chiropractor.
No.
I don't know about this.
You ever seen you could have a leased 2019 leased car. You burn it up. It got 100,000 miles on it. It was a fleet vehicle, a rental car. You could have a classic, right? Corvette is bad, fully restored, little to no miles on it. Age is not it. You see 100-year-olds running marathons or running races, right? Age is not it. Now, there is something to the accumulation of steps and time and activity on your feet. That's why people that accumulate more steps, carry more odd or awkward weight, walk on more uneven surfaces, wear crappy shoes and boots from the door, have developed issues over time. I had a 15-year-old young lady, and all her toes were kind of curled, and her toenails were jacked up like that. She was a ballet dancer, and she was really competitive. In 15 short years, she had done that to her feet, in effect. Well, if you add all the time on your feet, military-wise and otherwise, then you can see how that plays a part. So a baller's foot is a military foot. It's the same thing. That's different than somebody that might was an IT professional and worked from home and never commuted. You're going to see different changes to the bones. You're not going to see the same changes even if they're the same age. So it's not an age-specific thing. It is a time on your feet and shoes, weight, 2.5 times your body weight thing.
You had something, Terrell?
No, I did not. I'm listening. Yeah. I truly did.
I had patella tracking issues, right? Chondromalacia. That's a popular one with veterans. Can you break that down?
So the patella tendon, it acts like a pulley. That's the thin strip of tendon at the front of the knee. Pulley, you know, the little string system. So it actually allows, it's a cap over top your knee. It allows for you to kind of kick, that kick motion, right? And in general terms, you could have like the backside of that patella having an issue on the backside of the knee. I get a little squeamish when I start talking knees because I tore my ACL twice in my left knee. And the second time they took a thread, I'm sorry guys, but took a thread of my patella tendon and threaded it through. So forgive me at least a little bit. But like that can hurt, right? That leads to, again, lifestyle things. Can you do the Stairmaster at the gym? Can you do anything? You got to do water,
man. I don't know what to tell you. You did it yourself.
Well, you know.
Yeah, Doc. So when I had my knees, they took out my cartilage. And why do they have to remove your cartilage in that situation?
I don't know why they did that. It's just, I don't know why.
Why can't they put more cartilage in your knee?
Say again.
Why can't they put more cartilage in your knee?
They try, right? So they try with different things. People may have been on the call. They got these Synviscs or these little these shots they try to put in there. They tell you glucosamine, chondroitin, different over-the-counter stuff. They try to do microfracture surgery where they drill holes and try to create new cartilage. It's sometimes cartilage can be not avascular but dysvascular. It doesn't have the same kind of flow and blood flow things and nutrient issues. It's a lot of pressure in between those spaces. So once it degenerates, that's part of the problem, right? It's like you said, in best case scenario, oftentimes things will plateau, but oftentimes they're getting worse. Degeneration, it's kind of get worse by virtue of the name. And so sometimes you just might not have enough. Maybe it was damaged beyond repair. They might couldn't salvage whatever they saw in there.
I love it. Brett, I would like you to send me your link so I can share it too. We're going to move into a rapid. Brett, can you hear me? You got
yes, sir.
You got 2 seconds. I've been asking for your link. So we're going to go into a quick rapid fire and then segue back into the group here. So some good questions. A lot of things that were asked was addressed. So do you have any insight on the next move after a failed total ankle replacement?
That's hard. It's not a lot of failed total. I don't know what they spoke to you about, but fusion. I don't know if somebody talked about a fusion or trying again. It all depends on why it failed, right? If it's not, if it's a bone quality issue, if there was an infection in there, if there were things like that, that's a really, really hard thing to try to get through, because even with a fusion, you're locking joints and bones in place, and then you talk about the risk of another surgery. Will it take? That's a really, really tough question after a failed, kind of ankle replacement. It's really hard.
Check. Let's see. We got that one there. People saying hello. Good questions that were answered. Some folks are bringing up other things related to just the regular claim process they have going on. Let's see. Why not on top and not bottom of the foot? I guess that's relating to the nerving, tingling sensations and things like that.
It's actually equidistant, top and bottom. So you might feel it in both. Some people feel it differently.
Okay.
Mm-hmm.
Okay. Okay, let's see here.
Did you see that last one?
I can't see any of them. I got the Bretts going on over here.
Yeah.
The question.
I had a surgery on my. Okay.
You got it.
I had a surgery on my right leg from compartment syndrome. Now I suffer from lower back pain, and I can't see it anymore.
On active duty, I guess, was the surgery?
It said now I suffer from lower back pain, plantar fasciitis, tripping for 2 years and counting. What can I do to service connect? So who asked that question, DP? I didn't see a name.
That was Candace.
Hey Candace, how are you? Is your lower back service connected? Would be the main question. If so, we definitely can work with the amazing medical team to get you a Nexus letter to get that secondary. As Dr. Mike's amazing conversation, that it's all connected, right? It's all about what you can get a medical professional or to basically create the Nexus statement that says yes, this was caused or made worse by this condition. So secondary game, Candace, for sure. Oh, she said no, not service connected. We got bigger issues, Candace.
Alrighty, let's see here. We'll take a few more. Let's see. I had a show.
Would it be a cause of Planet Devil I saw?
Yeah, I'm gonna read it. Let me see. I had a mucoid degeneration of ACL on my left knee with moderate OA. Would that be a cause for plantar fasciitis in my right foot?
Compensatory pains are very real and can often happen, and that was the example I gave of Kobe Bryant. He injured one leg, and I think that's missed some time. And what you do when I say compensatory, basically you compensate. If you got a painful right knee, you'll limp, and then you'll favor the left side. So what happens to the left side? The left side is getting more weight and pressure. So often you'll have left-sided issues. Either, how many people have one heel hurt and then both heels start to hurt, or one knee hurt and then, both start to hurt. So, yes, there could potentially absolutely be a link between your one-sided knee mucoid cyst and arthritis. That's what you said, mild to moderate. It's not going to go from moderate to mild. It goes from mild, moderate, severe surgery, right? So very absolutely. And then the other thing is when you have a limitation of your range of motion. I know we talk about range and all of that. When there is a limitation of range and or again guarding or limping from pain, the short answer is yes, you can get pain, or it can be causal of the other side from favoring or compensatory pain.
So awesome. Someone said, I haven't learned how to walk like I don't have a major back injury. Someone mentioned they use a Segway to get around because of the pain on their feet. Again, this becomes to build the story of how that is truly affecting you, right? Who bought said Segway? How are you getting around? What can you not do? Are you not missing certain events that you cannot take a Segway to? Timmy wants to play baseball. Guess what you can't take to a baseball field, right? So it's little things like that that we don't think about. So guess what you do at times on that Segway or not having the ability to do things is, hey, you know what? I was going to make it out today, but I got some things to do. No, you don't want to go out there because you don't want to be the guy who has to take a chair to sit down. So guess what you do? You begin to recluse. You begin to get away from things, and that affects you.
Mm-hmm.
You don't want to miss your grandson's thing. You want to be the grandpa out there cheering him on, but you don't want to be the guy in the bleachers, you know what I'm saying, or back there with his, prosthetics and things that he might need or she might need. And that goes back to the point where how it affects you psychologically when you're dealing with these things, right? There are things that, hey, life happens, but when you jumped out of an aircraft and you did that 200 times and your knees are shot and your back is shot and you're barely walking, that's a different conversation.
Yes.
Let's see here. A lot of good stuff. People saying thanks. No. People are asking, hey, where can they try to reach out to you?
I'm on Facebook too, in group.
Yeah, you see us in the mastermind. We're in there. Secondary for gait. Let's see here.
Gait in and of itself is not a diagnosis.
Right, that's something like that.
Correct.
Like if your walk is going off or that's affecting, that's one thing. But what's the gait, right? So now your feet may alter your gait, which in turn makes you overcompensate or shift your weight one way, and that begins to do a thing. That's why anyone who's known someone who has, let's say, a really bad left leg ends up having a worse right leg. Because what you end up doing
Right.
is you go to the right leg now, and the good leg ends up being worse than the bad leg because you don't want to make the bad leg worse. So the gait becomes part of a symptom to a degree of how that works.
Yeah, it's basically an intermediary step between your next condition on the bad musculoskeletal on the other side.
I see your question. So one question that came in via email was, can we ask the doc, would he be able to address the person just had a CMP exam, bilateral knee claim for osteoarthritis with meniscus surgeries on both, looking at bilateral knee replacement now because of the extent of said injuries. The doctor examiner basically said during the exam that she doesn't believe the low back can impact the knees or vice versa. How best to then come back to that? So the examiner says, even though your knees are so bad you need knee replacement, your back is not making that worse. How would he best try to combat that mentally to push back, which is, in this case would be the option to do?
And so you it my thought process would be like you kind of say weave in the narrative of how this is affecting your lifestyle. It's hard, man, because it's a hard question because I do in my regular professional kind of before this life would sometimes get a second or last opinion that I absolutely did not understand at all how they got the first opinion. You know, people have bad days, to be honest with you. And doctors are people. I'm not saying that that's what happened in this scenario per se, right? But if you hunched over, right, and then you've been hunched or your back did something or your knee made you limp and it limped you one way, I get people, if I put a boot on somebody, they got back pain in 2 days after walking with the boot. You absolutely have a connection and issue if you got some kind of limp or knee. So did they get an orthopedist? Did they get somebody that didn't have their coffee? I don't know. It's hard, and I don't have a really easy answer. I just kind of go back again. Maybe you can document the chronicity. You can document the lifestyle impact. You can get documentation for those things outside of that face-to-face encounter with that CMP examiner. But I don't know why you would get somebody that would even not want to entertain that.
Right. And a good point there's at the end of the day the human element, right? There's a lot of different things factoring into that. Sometimes people just get it wrong. Maybe you had a bad day where you didn't focus on the things you should have focused on, and in high level review or in review of the thing, it turns into another thing. Last question before we go ahead and cut off here. Can you explain about bone spurs?
Yes. So remember I don't know if you was on earlier, but basically bone spurs as they relate to the feet, and most times they can happen anywhere where it happens, but more often it'll be at an area where we call of traction. So where one soft tissue or one muscle inserts into the bone. The Achilles tendon hooks into the back of the bone there, and then the plantar fascia on the bottom of the heel, kind of that we talked a bit about there. So oftentimes those ligaments and that tendon can pull at its respective parts of the bone. Remember the night splint is stretching those very things at those very areas, at the bone. And so over time, one can develop, as a result of that pulling, spur-like projections where the bone literally grows like a spur. It's not as if you're stepping on a spur, which is a common misconception, but it just looks like a hard extension of where the actual ligament or tendon starts off the bone. You could have completely asymptomatic or pain-free spurs. They don't have to hurt. Okay, so people say, what happens to them? They can go away. You can wear the right shoes or wear the right whatever. So you can have pain-free spurs. More often than not, there's some level of pain or some chronicity with it, or something that's at least intermittent. If it doesn't hurt all the time, it hurts when you do this, or it hurts when you wear these, or you try different things. So that's a bit about spurs.
Awesome. So on that note, we appreciate everyone who's out there in the interwebs hanging out with us for a little bit. Again, VA Claims Insider, this is kind of what we're doing here as veteran coaches. sharing some information, having a conversation. Again, does not substitute medical advice, does not act as representation. It's education. It's veterans having a conversation, trying to educate and ask the questions that you want to ask. So we're going to segue into our closed group and then continue there the after hour party. So thank you all for joining. If you're not a member, obviously you're not going to be in the group. So you see the ticker. Feel free to reach out, send us a message, put a comment below. If you want to work with any of our individuals, we are here available. So thank you all there. To the mastermind we go.